And like the big part of what we were first doing in Kenya was actually trying to figure out what is this, the low hanging fruit, the piece that we can actually connect with to make a big impact for, because we don't have a tremendous amount of funding ourselves.
To get started, what I would love is, we've got Steve and Wesley from Banda, right? Banda Health. And thanks for joining us. Love to just have a conversation with you guys about what you guys have going on. But first and foremost, I'd love to just kind of talk a little bit about you each individually, of, who you are and your background, what's kind of brought you to Banda. And then I'd love to learn a little bit more about Banda. You and I've already had preliminary conversations, so I'm not coming into this cold, but love to first know a little bit more about you, and then we can move to Banda. So I don't know if, Steve, you want to start, and then we'll pass it over to Wesley.
Okay. Josh, thanks for having us on. So my background is I'm a medical doc. I was 7 years in private practice in the U.S. in the suburbs in the 90s, and then my wife and I moved our family to Africa in 98, and we've been there since. Basically, all that time has been in two different mission hospitals, so it's kind of the last place someone who's really in a vulnerable point gets to. And I conned Wes into joining me many years ago to see if we could figure out how to use technology to take that effect for the people who need it most, take it down to the grassroots level. So that's what we've been trying to do. And that's now called Banda Health.
So my background is, for a long time I was a software developer, software architect, working with software development teams. Really, that was the realm that I worked in. And then in 2012, Steve, as he said, conned me to come over to Kenya. It was not a con. But he presented the opportunity. Put it that way. And
there you go.
And I got started with Steve, creating what eventually became Banda Health. So these days I'm not really doing much software development. I joke that I help people do real work. So I'm kind of in the background trying to move things along. While on my better days, I'm able to help with the technical decisions and work on that side of it. So yeah, it's been a joy to work alongside Steve and be able to be involved in this project.
Awesome. Well, cool. Yeah, the whole reason we're here today is because I learned about Banda Health through a friend, and they said, you've got some really cool things going on, because we talk about ventures unscripted, and we talk a lot about, hey, there's a really cool journey to get from 0 to 1 of how you actually got from here's a problem and this was the solution and all the in between, right? So like a lot of people just see the end solution and they see how it helps people. So maybe we can start with, what is Banda Health? And then we can rewind a little bit and say, here's the problem it solves, and then rewind and say, how did we arrive at Banda Health as it is today? So I guess I'll ask either one of you guys, whoever wants to chime in, what is Banda Health?
Well, I'll jump in on that. So Banda is basically a little software startup that came out of the faith-based sector, and our goal is to connect with and then empower frontline health providers, which are little clinics that have no doctors, no accountants, that are working in slums and villages, and just help them do what they do and do it better, both through technology as well as through bringing some relationships around them.
And when you say, did you say doctors? It helps doctors or helps clinicians, or what's that exact persona that you're?
That's a great question. So there are essentially no doctors in these clinics. So if you're one of the poor people in the world, this is where you take your kid first, and it'll be a medic by a variety of names. Occasionally it'll be a nurse. Sometimes it'll be somebody with a little bit of pharmacy training, and you will walk in. You would call it a little storefront clinic. So it's just on an alleyway in a slum, and there'll be a building. Typically they're registered with the government, and you'll walk in and they will figure out what's wrong with you and sell you the drugs that they think they need to treat it. So, yep, typically they could be a couple people working there. They could be 20 people working there. They could deliver babies.
And that's far different than a Western mindset, right? Is like you have something wrong, go to the doctor. You have a lot of options, a lot of different doctors, and versus if we're talking about kind of third world countries here, right? More in that realm. Would you agree with that? In this, in particular, what is your demographic, right? Your place that you're focusing on?
Yeah, no, this is very much majority world, people who are surviving on a couple of dollars a day, often in an urban setting, so it's very tough to do it. They tend to be a lot of people day laborers, so if you don't work, you don't get paid. They hustle a lot, and these everyone listening to this call is probably in the top 5% in the world with money, and these people will all be in the bottom couple percent. So it's a world that honestly. It's hard to imagine how you would take care of your kid when you have that little. They literally make a decision between taking care of one kid and feeding another kid. So
it's a completely different mindset. Yes. Yeah. My goodness. Yeah. So and how did you guys? It's interesting. We talk about this because that is such a big need. Around the world, because we talked about. You said 5%, right? I mean, we're in the kind of the 5% that's listening to this. Most of the people that would be. So, with that, it's like, how did you guys arrive at like this is a big issue, right? I mean, like, did you guys? Because I have to imagine, when you're finding and you run into that problem, it wasn't just we got to go help these people. It was probably your firsthand experience, or maybe it was working with another organization. How did you guys discover this? This was a huge issue.
And like the big part of what we were first doing in Kenya was actually trying to figure out what is this, the low hanging fruit, the piece that we can actually connect with to make a big impact because we don't have a tremendous amount of funding ourselves. And so, these small clinics, they have an outsized impact to the communities that they're in, but also to being able to have a positive impact for the patients that they're working with, especially obviously the good clinics. So anything that we can do to help them be able to spend more time with patients, be able to make better decisions when they're with their patients, make sure that they get the right medications when they need those medications, that has a huge impact for a very relatively small amount of effort if you compare it to trying to work with like national health systems or work with big hospital networks where there are big hospital networks. So that was we spent a little while trying to figure this out, working alongside a lot of in our case Kenyan counterparts who were living that experience, and some of which had experience in the U.S. as well as in Kenya to be able to help translate. And some people like Steve who have a tremendous amount of experience both in the U.S. as well as in different African countries who can kind of translate between those two different worlds because like Steve mentioned, it's hard to imagine the differences. Like in some ways they're stark and it's obvious.
Yes.
But then there's a million little ways too. For example, when we were first getting started and we were connecting with some medium-sized hospital-connected clinics, I remember thinking that this technology that we're bringing, that was the big advantage, that was the big piece that we can bring. And of course, I think that because that's the piece that I work on, right?
Technologist, yeah.
Right. But that's like really not the case at all. And increasingly over the years, but specifically in those first few years when I was there, it became very apparent that technology can enable a good organization, a good person who's in a role to do what they're doing better. It can also enable somebody who's bad to do a worse job. So technology is not the important piece. It's empowering and enabling people and the processes that they're using to do what they're doing and do it better. So that's what we're trying to do now with the small clinics we're working with.
That's such a powerful statement because, a lot of the people I've talked with often think that it's the technology that is the transformation agent. It's the thing that will bring them to the next level versus no, it's not. It's actually working right beside the people, understanding their core problem and really solving it well. And then figuring out the technology piece comes. And I want to so badly, we'll dive into that in a second because I want to ask more about that technology piece. Before you do, you said something, Wesley, that you said, work beside, you guys have worked deeply beside these Kenyan kind of counterparts out there. And what did that look like to work beside them to figure this out? Because you obviously have this thing in front of you to figure out, well, what is it that we actually build? Because right now you've got something you've built, but how did you in that scenario figure out what to build? Because obviously I'd have to imagine there's a lot of conversations that had to be had with these folks to figure it out and come beside them and really help them figure out how to help them best.
Well, I can just say that in general, going into it, we knew that one of the critical pieces was somehow combining both the clinical aspects of running a hospital or a clinic as well, so like the medical side of things as well as the financial side of things.
Yeah.
So in general, you tend to get systems that are either medical based, they're gathering a lot of patient related information, and then somebody tacks on the financial piece, and so the financial piece isn't particularly good. Or you find the inverse of that. You find somebody who found a good financial system, and they tack on a subpar medical system onto it. So what we wanted to do was try to do that a little bit better. And so working originally in more of a hospital setting, we were working with open source platforms to be able to leverage both excellent medical software and then tie into the important pieces of like the financial piece. So we're not talking about like financial CFO level kind of things. We're talking more at like point of sale, inventory operations, those kind of things. The things that are actually like on the ground and what you have you're paying your people to do, and then that can flow into like some kind of financial system. So that was originally where we started, and that just came out of, like I said, the experience that Steve and others had and just kind of seen struggles both from a doctor's perspective working in an institution as well as being a hospital administrator and seeing it from that side of things. So that was where we started, and then that kind of informed us. We gained a lot of experience. We had some good impact there, and eventually that morphed down into the smaller place.
I was just going to ask you a quick question. I think you were going to get to it, Wesley, of like saying, what are some pivot points that you, as you were learning, of like, did you overbuild this first version, underbuild, or did you build the right thing you felt like the first time around, or how have you guys pivoted and tweaked along the way and what are some of those pivot points?
I think one of the big areas that is that's really different in the developing world is that you can't really rely on having local access to servers, reliable power, even reliable internet to a certain extent. And so any solutions that you come up with that expect that you're going to have a server running in a clinic, you're immediately at a disadvantage. And so a lot of the kind of hospital management style platforms are going to assume that. There's not very much, especially we started in this a decade ago, and SaaS options, so software as a service options, things running in the cloud, those weren't as prevalent at that time, and they certainly weren't as available in the developing world at that time. And so we originally we were using a platform, an open source product called OpenMRS, which is Open Medical Record System. It's a very popular open source platform for gathering medical data. And we were hosting that locally, so we would set up a server in a clinic, and just the cost of that, the server, that's not an insignificant cost. But then you need all the stuff around it because your power is up and down and comes in crazy bursts, so you got to have it protected, and then you got to have it secured, and then you got to set up the network for it. Like it's on and on and on and on. That doesn't scale. You can help 1, 2, maybe 10 places do that, but if you want to get to 1,000 places, there's no way in the world you're going to be able to effectively roll out that many servers when you're a small startup like Banda Health is. So that was a pivot point where we recognized, okay, we've learned a lot from doing this. What we've learned is that you can't we can't scale this up. We have to come up with a better option. But then also, even from the user's perspective, in terms of getting a system up and running, if you tell them, okay, we need to install a server, we need you to get all of your data, we need to have this big upfront setup and long implementation phase, that's a big barrier. I mean, people oftentimes don't have very much time to begin with, so we're kind of making it more difficult for them to get up and running. Versus if we can just get something where you tell us what you want your clinic name to be, who your users are, and then we'll get you up and running in a matter of a couple days on our side, with what we expect you probably have for your products, and we can change those, and what you probably have for your patient workflow, and we can change that. Now we've dramatically lowered the barrier to entry, and we have it all running in a easily accessible place. Being able to tailor it to run on really low resource computers, on relatively low bandwidth connections. It works, working offline-ish when needed. Although I'll say that's a work in progress more than it is actually done. But in any case, it's more aspirational. So those are some of the big pivot points technically that we came to.
I mean, while they're very technical in nature, they're very interesting things that I think take for granted, right? Of the people, even listeners, of like, you're going to have a stable internet connection. You're going to have servers. You're going to have, like, you could fill in the blanks of all of these. And working with a medical facility, it's like a part of the process is setup. And it's like, well, your target audience, your person that is actually needing this is like, look, I'm seeing all these patients, a ton of them a day. I don't have time. I don't have budget. I don't have support. I don't have anything. I just need to like get up and go. And so it's all of that is very eye-opening as you kind of walk into this and how it even applies to the tech. That's a very interesting set of points you raise, Wesley. So yeah, what about for you, Steve? I mean, you've been in this, right? And been in, working even prior to being the product built, that's where the basis of the first version of the product was built. For you, what are he's got some technical pivot points, but what have you seen is like, hey, when we first started building this, we missed the mark slightly or largely in these couple areas, and here's how we kind of had to tweak it and pivot it along the way?
No, it's a great question. I think one of the early things, and I'm a doc, but I mean, I've run hospitals and I've owned and run a practice, and I understand the importance of business. But very quickly, you get to, when you're doing you do social innovation for impact, but you have to get there through value and obviously through resources. So realizing what is the value for a clinic. And somebody, Kenyan senior doc, told me, he goes, you have to make essentially the CFO happy before you make the medical director happy. And in this case, they're all the same person. But their worry is like, who stole my Tylenol? I mean, that's what they're, because that is their money. They don't have a lot of it. So on the one hand, early it was a pivot. I'm thinking a clinic system needs to have a medical record like we put in the 90s in the U.S. in my practice. No, they have a set of needs. Then they overlap. But so the first thing was realizing they need their business stuff done in a certain way. The second thing was, though, they had to go back, and when they said they wanted electronic medical records, I had a certain mental image in my mind of what that looks like. That's not what they're talking about. And so they had to reconvince me. I mean, not really me, but the process slowly convinced me, like, no, they do want to capture clinical, but not like we do. You would expect your doctor would have every note of every phone call, everything in there. No, they got certain things they want to track and certain things they don't want to. Why do they even want to have a diagnosis in there? And understanding what the value is, no, there's a government report they have to do. And it is helpful a little bit for them. They feel better about it. But figuring out what's that government report, great, let's get that taken care of for you. Now, the impact is that you're recording your diagnosis, and now we can start seeing what are you prescribing and help to inform that decision. But the value is, no, I need this report done, and I need to take a minute, not a day to do it. So it's some of the what are we doing, and it's been very much doing it lean helps you understand. They'll tell you. They'll give you ideas anyhow.
So it sounds like, I mean, there's a couple different ways I look at this. Is like, you oftentimes can throw those things to market where you're building it, and then you're like, gosh, I built the completely wrong thing, and you have to kind of do a 180. It doesn't sound like one of those. It sounds like got it to market, and you're like, we kind of overbuilt or overshot or misshot of like exactly where the value or end target is, and you kind of just tweaked along the way, and you're still making your way over to that. Would that be an accurate statement? Yeah,
with what we're delivering now, that's very much it, is making mistakes very quickly, some of the big stuff as we look. Eventually, we need a whole clinical piece on the back, like we have a business piece on the back. But waiting to build a big clinical piece is like, no, that's a lot of time and money, and that's going to slow us down forever. We can start testing questions about what do they want from a clinical standpoint and how do they want it. We can do that with our existing system. It's not the way we will build it out in the future, but we can quickly see, and when we give them something, we can instantly see, great, that worked, or that only helped these 4 clinics. Like, what's going on with the other 62? So.
But to get to that point, we did actually have a very significant pivot technically. So originally we were, like I said, we were based on OpenMRS, which is this open source, very popular, especially in the developing world, medical record system. But then around 7 years ago, we recognized that this wasn't going to scale for us, and particularly around the fact that it wasn't a multi-tenant system, meaning you couldn't run multiple clinics off of the same database and have each one of those clinics separated so that you could only see, one clinic could only see their data and they couldn't see somebody else's data. So that for us was a big roadblock. And so we kind of had to revisit, okay, if our goals are going to change now, where we're really looking at a SaaS option for this software going forward, what does that imply then for the technical backend? And so that caused us to transition to the business system that Steve was talking about in our backend, which is another open source system called iDempierre, which is an open source ERP. So that was a very significant technical transition, and then we had a big technical transition that happened, or pivot. I guess it's not really a pivot; it was more of an extension of that platform after we'd been using it for about 1.5 years or 2 years, where we just found that the user interface wasn't what we needed, and the effort to make it be what we wanted to be, particularly around the area of simplicity, we were just going to continue to run into roadblocks. And so we created our own front end on top of that. And obviously anybody who's done that kind of development recognizes that there's significantly more effort in creating your own thing from scratch than building on top of an existing platform. But once we got that done, and it took about 6 or 8 months to do, once we got that done, we can now make changes significantly easier. We also have, I think, a much more clean and responsive UI as a result. So it was worth the effort, but it took a while to get there. But I think the important thing for us was that we didn't try to make that UI our own UI from the beginning, because undoubtedly we would have made more mistakes than we did. I mean, obviously we didn't do it perfectly, but because we kind of went with the initial system first, which had the user interface, user experience flaws that we knew, we were able to learn the particular pain points that we, some of which we knew, some of them we didn't. And so we had to kind of go through that process, and the result was that we were better than we would have been, I think, if we would have just started from the beginning. Because it would have taken much longer and all that. So
that was a huge pivot. The other huge pivot, and Wes may have mentioned this when I dropped out for a second, was the question is, I mean, the big thing is, how do we use technology to really help people who are the most disadvantaged, help them with their healthcare? But what solution is that? You can look even today online and see who's doing that, and it's like, no, there's multiple things that you could do. So for us, it was figuring out with our unique background and skill set, what is the space we're in? And we initially we did it offline for clinics, so there was a bit of a technical, but that basic idea was there. But most of what happens that's scalable right now in global health is niche products. So maternal child health, or getting an ambulance, motorcycle ambulance to come pick you up when you're pregnant or something. So they're great, or pharmacy specific things, but they're a niche. And we looked at that, and we actually did some pediatric surgery. We did some inpatient stuff based on OpenMRS there was potential high value. And when we made this pivot in 2016, and decided, no, we're going after clinics, and we're going to do business and clinical both, which meant we had to finish up some of the legacy work that we had done, where we learned a lot and left stuff that's still being used. The big pivot was exactly what are we doing, and that got clear over time as we worked on a few different things. So
I love that. I mean, both you guys speak really clearly to the fact that. And you guys are following kind of lean startup principles of, hey, you know what? We're going to, instead of going out and building our own custom thing, like you had said, Wesley, of if you started there, it would have been a lot trickier to kind of more quickly pivot, and it would have been longer tail to learn what the patients actually need and the end customer, your end customer actually needs. It was much, much faster to throw out. I like to call it bootstrap. You bootstrapped and said, what's already existing? Let's throw it out there, and maybe we have to customize and set it up, but let's throw something out and see if we can provide value immediately. And Steve, you articulated, we used an existing system, and we're trying to ask questions and utilize it in a way that, while we might build it differently in the future, we're trying to figure out, should we actually build it? And it's neat to see you guys' bootstrapped approach, which a lot of entrepreneurs struggle with, of saying, hey, it's got to be perfect, right? Because they look to the Apples of the world and people that have a lot more money and a lot more deeper pockets and are not, necessarily startups even, and that they're like, hey, we know what to build. So it's really cool to see how you guys pivoted along the way. Through all that, what do you guys think that some of the big lessons learned when launching this have been for you guys? And I'll add,
Steve?
while you're talking, maybe words of wisdom.
I'll do lessons learned to go together with words of wisdom. One of them is the one, and someone just had me on a call as they were in a space that we're in. And one word of wisdom was just, no, your customer will tell you, these people already had 50 customers. And I said, no, just build it and pick your top two and just let them use, don't send them a finished product. Just start getting their feedback on very short cycles, and their input. But the one that, probably one of the things that was most helpful, and again, lean, the lean startup idea for me as a non-tech person, so agile and waterfall and all that stuff is not part of my vocabulary, and I'm not agile even not technical wise. So it was rough, but that was a very helpful framework for me coming in and realizing this is innovation. We're doing something. You need to fail fast and get over your obsession with things being perfect right out of the box. Like, no, people are happy, and find your right early adopters. But the other one, this strategically as a company, I mean, it's a nonprofit company, but the issues are the same. There's a lady, Ann Mai Chang, that took the lean startup idea and looked at it from social innovation. And so she's speaking to donors and to social innovators. And so we're very much a social innovator in that space. And she said, you have to do three things. You have to tick all three of these boxes to successfully make an impact. And that is, you have to focus on impact. So what is it you want to transform? And we want to see good healthcare for people who have no money. And good healthcare is just the right diagnosis, right treatment, right time. It's a simple construct. But to get there, you have to deliver value. And so you have to tick not just the impact box, you got to tick the value box, and that is the value to the user. And one great example is the clinics. Many of them may or may not be concerned that they have a problem making a diagnosis. They're often, and we're all comfortable with what we can do. Do we think everyone's diagnostic ability could be taken up 10 levels? Sure. But that's not their worry. But their worry is that now they have a little medical record, they would like that note populated. So we need to get to the impact we want through the value that they feel. And that happens all the time. And of course, the third box, you got to tick resources. And if someone can afford what we're giving them, that's not who we're looking for. And so we've got to figure out, how to sustainably put together an economic engine in the social sector that can keep this thing going. And so so I think that one piece of advice is, if you're in the social sector and innovating, lean impact is well worth the time.
That's awesome. No, I mean, those are some really quality pieces of advice. I really like your approach that you just articulated, Steve, of, hey, get something even partial out there, throw it out there. They'll tell you what they want, iterate on it. Don't wait to get something out to the market. I love that. That is so pivotal that a lot of people just forget. And concentrating on the user is what I'm hearing too, is the theme of like their needs, delivering value, understand the value you're delivering. That sounds like core to what you're saying, is like, if you can't understand the value that you're delivering, then it's not going to have any social impact if you can't match that value box to your end user. So yeah, that's great. Leslie, how about for you? What have you learned in this process and words of wisdom?
I don't know about wisdom, but I can tell you some things I've learned. I think one of the key things is not holding on to the technical choices that you make too tightly. And what I mean by that is there's been, like I talked about earlier, there's been a few different instances where we've had to choose to move to something completely new, or at least add something completely new, whether it was that transition from OpenMRS, which is excellent in the sphere that it works in, to that move from OpenMRS to iDempiere, or in the move from the iDempiere front end to just using it as a back end system and creating our own front end rather. In both of those cases, it would have been easier to kind of leverage our existing experience and code base and all of that with the old platform that we had, but keeping the perspective of where we wanted to go in place, it became apparent that we need to make a change. We need to transition to something else. Otherwise, we're going to be stuck for a while. And I feel like in the lifetime of any project, you get a few opportunities to do those kind of things. You get very few opportunities in general to do any kind of greenfield development where you're doing your own thing fresh. So you need to be careful and pick your moments very carefully about when you do that. And you also just need to take advantage of that to make sure that you're taking advantage of the technology you want to use, so that you can find developers to work in that you think can scale to the level you need it to scale to. Because once you make those decisions, it's really hard to unmake them. And if you find yourself making those kind of transitions on a yearly basis, then something's quite wrong. Or I guess you're Uber and and you have ridiculous growth and probably lots and lots of money. So we didn't have either of those things. So we had to be very careful about how we were doing things. So I think for me, it took me a little while to kind of break out of that mindset of feeling like we have to leverage the investment that we've made in a technology platform. I mean, obviously you want to do that, but at a certain point, it's kind of a sunk cost, and you don't want to continue to do that just because that's what you know and that's what you have experience with.
Yes. The two things, that's such good advice, Wesley. The two things. So my background as an engineer, because that's where I come from, it resonate completely with what you're saying. So the two summaries that I always say, and we say it on our team, is one is, I think what you're saying, one of the things you're saying is, as an engineer, it's really hard because we're classically taught and classically think to build the thing right. You pop up in the hood, you make it run fast, you make it run efficient. Look at the cool stuff that we built. But there's a difference between building the thing right and building the right thing. And so understanding the right thing, like we could make all these gizmos beautiful under the hood, but if no one buys the car or the thing we built, then it's like you got to throw it away and kind of start over or tweak it vastly. So that's where I think I can resonate there with one of the things you said. And the other thing is, the phrase that comes to mind is, be married to solving the problem, not be married to the solution. And so those are the two things that come to mind. Is that jive with you, Wesley, of summarizing those couple things?
Definitely. Yeah. And I mean, a lot of that is driven for us by the fact that we don't have a tremendous amount of resources. We have enough. We don't have a lot of developers. We don't have a lot of time. So we have to be super focused on exactly what are we going to do. And if we're going to take 6 months to transition from one user experience to another, that's a huge amount of investment of our time. And so that means that we need to be very sure that doing that is getting us, like you said, to the solution, and not just not just some exercise in creating beautiful code.
Yes. That's right.
Which is valuable, but that's not what we're here to do.
Right.
And Josh, maybe just to the embracing the problem, not the solution. A couple years ago, a number of us were at a meeting with a lot of other programs doing a lot of other stuff, and we were kind of there listening. And when it was done, two of our senior Kenyan guys, who were just very humble, gentle, understated guys, at the end I would just ask them, so what'd you think, who'd you meet, whatever. And their observation was, they said, we get a lot more done than a lot of people who have a lot more money. And I said, interesting. I said, why do you think that is? And they didn't hesitate. They said, no, we focus on the customer a lot more.
Yes.
And I thought, interesting. All right, they saw it, and they were both tech guys. And I thought, great. Because, it's every 2 weeks we argue over, is this really the next most important question we need to answer?
Yes. That is awesome. Yeah, so true. You can move so much faster by, to quote you, Steve, failing fast, understanding your customer deeply, and being okay. Like Wesley, you had said too, of honestly, if you throw something out there like an advanced EMR system, and you're like, we don't need any of this. This is not the right thing. Being okay, pivoting, and saying, okay, well, let's go to what the actual customer wants, desires, and solving the problem, not being married to, well, we have all this beautiful code to this EMR system, let's just use this. And it's like, well, that doesn't solve the problem. It just marries us to the solution. So that's great. That's awesome. What are the next steps for Banda Health?
I'm happy to take a shot at that. Let me just say one other thing that I've thought just listening. So the tech and the strategy is all cool words of wisdom. But another thing I definitely have relearned, and I'm an Enneagram 5, so I love data, and I'm not supposed to enjoy people that much. But I've realized how nice it is to do this with friends and to do this with people. I mean, paramount on that is getting to do this with Wes. So this is now 10 years of we're together, we're far apart, whatever. But it has been gorgeous. The other piece, though, is just with our team and honestly with these clinics. These guys, I'm too old now to, do anything else. It is great when you get to just go hang out with them or just see what they're doing or see excitement or just walk through some of your own journeys with them. So, doing it with friends and making friends on the way is
important.
Yeah, adds a lot to the journey. Next steps is... we are at the 1 mile marker of a 1,000-mile journey right now. And so on the value side, we need to be in 1,000 clinics. We're only in 66 or 67 this week. And so there's obviously a lot we have to do to both figure out how to scale. And that is not so much the technology as it is the learning, finding the right type of people, helping them onboard quicker, and delivering a product that just more and more fits how they need to do stuff. They get a new person working at night and they don't have time to train that person. It just needs to work. But then the other thing is just on the impact side, the little paradigm of right diagnosis, right treatment, right time. We are right now working with clinics who give care at the right time. We are helping them begin to at least have medicines in stock. So our tracking system and everything helps them. We're getting there. There are some fundamental issues of if you're going to transform stuff when you can't just take everyone out for 10 years and give them a lot of education and then have them go back to where they were. No, there's things you can do that technology can do. And so building out the clinical side of what we're doing, not just as an EMR, it'll be nice, there'll be some of that, but there are other fundamental issues that need to happen that will involve other relationships and a lot of learning. So that's, so get bigger, but get a whole lot better at being able to help people.
Yes. Awesome.
Yeah, and I think the root of that is the not being reactive in terms of, not for us, but not like we're able to give information to clinics to help them react to what has happened, whether it's in terms of stockouts or maybe identifying that they're not recording diagnoses or whatever it may be. We want to get to the point where we're able to proactively tell them that, well, maybe help them with regards to their diagnoses, doing some kind of clinical decision support so that really you can identify, can I help this person or do they need to go to the hospital? Or do they need to, some other place? Because that's the key thing, right? Like, if they need to go to a hospital, they probably need to go quickly.
Yes.
Otherwise, like Steve said earlier, they're getting there and it's too late. And that's obviously the thing that we can help with, if we can be able to help with those kind of decisions. The other piece is identifying, potential supply chain things or potential financial pieces before they happen, rather than you've run out of something and now you can't give it to the patient when they need it. And you can't make the small amount of financial gain that you survive off of because you don't have it in stock. So being more proactive to let them know about those things before they happen, rather than letting them know, okay, this has happened. I think in general there's a whole bunch of different aspects of that, but I think that's a big part of the direction that we want to go in next, from a product and technical perspective.
Such a great vision. Well, really, really needed, it sounds like, and definitely across the world. So really admire what you guys are doing. And I appreciate you coming on and sharing. Any other closing remarks that you want to make?
I'll say just thanks to a guy who passed away yesterday, Paul Farmer. Obviously is in the global health space and has made a mark, and he and his family have paid a price that few others have done. So thankful for that guy and his team and what they've done.
And thank you, Josh, for the opportunity to share just a little bit about what we're doing, some of the lessons we've learned. Thanks, Steve, for sharing some wisdom. I wish I had some to share.
It's been a lot of fun. No, you shared some great wisdom. So I appreciate, again, you guys coming on.